This is just a brief overview of what all we're going to go through today. So far, we've got a good review of how concussion occurs, all of the physical signs and symptoms, how we evaluate those. I'm going to kind of dive right into the cognitive symptoms and focus more on how that student gets back into the classroom. Same note as what Tom stated. I might refer to the student, student-athlete, athlete, patient, child. I'm referring to the same noun of person. So keep that in mind. So what are some cognitive symptoms that the student may present with? Keep in mind we are working with students 0 to 19 or K through 12 students. We do see some college students, but it's typically the 0 to 19. These patients will not come in and say, gee, I really have a struggle with concentration, or yeah, I have noticed my processing speed is a bit slower. They're not going to use big words like that. But when you do take your history, you are going to ask them how school's going. Are you having any troubles learning? And they might say something like, I can't remember what I went over in school today. Or they might say something that they tried to take a test and they knew nothing on the test because they're struggling with their memory. If you ask them about reading, they might say that the words move on the page. Or they might say something like, I have to read the same thing over and over and over, and I'm still not learning or understanding what I'm reading. So just kind of read into how they're answering your questions about school. The kids K-6 might come in and their parents might report they're having behavioral issues in school, or they can't seem to sit down still like they used to. And that's because the kids are struggling to learn at school, and it's not how school used to be prior to their injury. So just keep those in mind as you're taking your history. All right, so why are we here today? Tom talked about the LB 260, which is the Concussion Awareness Act. This was passed back in 2012, and that's a very important legislation to keep all of our athletes safe from returning back to sport prior to healing from their concussion. But what we realized 2 years later is that we were trying to get kids back into school also, and they were having some struggles. And so this Concussion Awareness Act was amended 2 years later to add the return to learn process. And what that basic analysis of that is that it's just a requirement for schools to provide academic accommodations for that student due to their concussion. This is the exact wording of the bill. And just keep in mind that this bill went into effect July 18th, so yesterday, 5 years. And most schools up to this point have a very robust concussion policy that includes return to learn. 5 years ago when this first came out, it was kind of a struggle. Schools were kind of struggling with that, but most schools, especially in this area, kind of know what to do with concussions in the classroom. So what does this look like? There's no set standard that says it has to be this way, like the return to play process. It can be informal or formal. It can start as soon as a school is made aware of the injury. So that's where that communication piece comes in. You do not have to have a doctor's note to start, contrary to what some schools or some parents may believe. The school, as soon as they know that child received a concussion or a head injury and they can see that they're struggling in the school, they can start those accommodations right away. That's also why it's important that everybody who is involved with that concussion management knows what's going on and keeps everybody in the loop. So that means if somebody was injured over the weekend and they come to school on Monday or Tuesday, they may or may not have seen a doctor, but the mom or the student can report to the school office, counselor, school nurse, yes, I hit my head this weekend, or I was in a car accident. The school can start that return to learn process right then and there. So just a small history on return to learn, especially in the state of Nebraska. The large group of education specialists and medical specialists who deal with concussion primarily teamed up with the Nebraska Department of Education to create a very robust document called Bridging the Gap. It is a very thorough document that helps get the concussion back to the classroom, and it has already been updated in the last 5 years. So that just kind of shows us that concussion is evolving. What we're teaching today and what we're talking about today might change in the next 6 months. It might change in the next 2 years. So just keep that in mind. This is the website. This is also at the end with my references, but that has the exact document that you guys can look at for reference. So a question that we get all of the time: when should my child go back to school? And as the previous presenters have spoken to, that 1 to 2 days is pretty standard enough time of rest for most students. Anything 3+ or 5 days, they can actually develop an aversion to school, especially the K through 6 kids. If they realize they don't have to go to school, they kind of don't really want to go back. So they kind of like this game. So just keep that in mind. Obviously, if kids are struggling just with their activities of daily living, we want to make sure that they can do that first. But just get them back to school, back into their regular routine, back amongst their peers. That's what our goal is. And this is just a little visual for that. So when the student returns to school, again, each concussion is different. This is not a stepwise progression, so not every child has to go through this progression. Some students are not even affected by the concussion academically, and they're able to return to school with no accommodations. Other students need more formal plans and end up on an IEP or a 504 by the time their concussion is over. So just keep that in mind. If the student returns to school half days, and that works best for them, or even 1 to 2 hours, we recommend that they alternate their half days, so that way they're not missing a full week of algebra or chemistry, because that's their first and second hour. We want them to alternate so they're at least present in that class 1 or 2 times a week. It's also important to note that the student should be fully functioning in the classroom before they are able to participate in any extracurricular activities on Friday night football game or the band concert or cheerleading. Any of those activities, they have to be fully functioning in the classroom first. They can't be attending school half days or getting help on their tests and then go play on a weekend activity. Okay, and you will have coaches and parents that will try to fight that. So, and that's also part of the legislation too. So, what can some of these accommodations look like? I will let you guys read through all of those. Not every student, again, will receive all of these, and not every class will need to accommodate the same way. So a math accommodation will look different from a chemistry accommodation, will look different from an art or an English class. So each class and teacher will be able to make those specific accommodations for that child. As always, it's important to work as a team, so all of the teachers that are in charge of that student's learning should work with the counselor or school administrator, school nurse, whoever's in charge of that concussion management team, and make sure that the best plan is set up for that student. The last one on here, lunch in a quiet place. This is sometimes not the best because we don't want to have seclusion for the child, and sometimes that's the best time for them to get back into their normal peer and social interaction. However, it's sometimes hard for some teachers or coaches to see the child laughing and having a good time with their friends, but then they can't take the test during 6 hour right after lunch. So just keep that in mind, and that's because their brain isn't working hard when they're eating lunch with their friends, but then they have to go sit in a classroom and learn. That's when those symptoms come back. Just a few more accommodations. Again, the limiting of that isolation is very important, especially for those middle school and high school kids where school's already kind of a tough place for some kids, and so we want to try to keep them as social and back in the mainstream as possible. So I'm not going to go into a lot of detail about long-term accommodations, but this is definitely something that comes up, especially in the classroom. A 504 plan, an SAT, IEP, all of these are some terms the schools will use when it comes time to make those accommodations for students. Not every school uses the same terms. Not every school does the same thing. And again, it's variable based on the level of that child, what grade they are in school, and how severe their concussion is. Like we've learned already this morning, most concussions heal within that 1 to 4 weeks in the pediatric, and then if it's anything longer than that, they might consider these long-term accommodations. But I have seen schools put concussed kids on a 504 plan as soon as they know about the injury, and that just helps educate all of the other teachers that this kid is going to need some accommodations while they're healing at this time. In addition, some students are already on an IEP, or they might already be receiving special ed services because it's not just the athletes that receive concussions. So sometimes in that case, those plans can just be adapted and adjusted for the short time period, which is a concussion in the school is a short-term disability. It's not going to last their whole career, most cases. So just keep in mind, those are things that can help get the kid through the school. Standardized testing always comes up, it seems, especially in March or the middle of football season. So these are some accommodations specific to standardized testing. Again, if the student is already receiving those accommodations and that test comes up, those can just translate on over to that standardized test. However, for some larger testing like ACT and that sort of thing, the school will have to make some extra accommodations to make sure that that school, or make sure that that testing entity knows that these accommodations are needed, but they're definitely available. And these are some of those testing. We also have kids who are doing AP testing, or they might be getting dual accreditation, so getting credits for college and the high school. And concussions occur at the college level too, so whatever school those classes are being taken through, they have an academic accommodation plan for concussions too. A lot of times the school or whoever's in charge of the academics at the college level will make it sound like these tests can't be made up or things can't be changed. But there's always rain-out testing or extra testing dates. There's multiple other reasons why kids cannot take the test. Car accidents, other types of injuries, illnesses, other things that take kids out of school. So there's always other options. It's just sometimes hard for schools, parents, or even the student to think outside the box with these kinds of things because you can't see the concussion. So some unique situations. The kids who are high performers outside and inside the classroom really struggle with concussion because they don't like to change their academics. They don't like to ask for help. They don't like to get extra time when they take tests or kind of veer off anything of what they were planning to do with their high school career. So those kids actually take an extra time to educate that child to say this is only a temporary accommodation. If you just take a little bit of breaks or a little bit of time, then you'll be back to your normally functioning sooner than if you were to just keep pushing these off. So those kids are really hard. On the contrary side, the low-performing students, these kids might already struggle with academics, their attendance, or they might be missing homework, and the concussion is kind of like their answer to making an excuse for, oh yeah, that's the reason why I couldn't hand in all of my homework. So, for example, like if a concussion is received 2 weeks before the end of the semester, but they have 10 weeks worth of missing assignments, these accommodations only start for that 2 weeks that the concussion occurred. They can't post-date things like that. That's not how a concussion works. So educate the child about that in the school. Finals week and end of school year. This is sometimes, concussions always happen during finals week, or their concussion symptoms are still affecting them during finals week or the end of school year. And this is the situation where the family will need to work with the school, because there is always a school administrator or somebody at the school post finals week and post the end of school year, where the child can go back and take the test 1 or 2 weeks after school has gotten out. It's not the most ideal, because a lot of families plan vacations and trips around that time, but things need to be altered, and that is definitely an option. Dual credit we already talked about with the college. Sometimes students think that they just should take the test, and some teachers don't always provide these accommodations, but it's important to just keep the communication lines open, so that way the student has an opportunity to retake the test, even though they thought they could and they did horrible on it. So just keeping those options open. So these are some kind of answers to those unique situations. The kids who already are high-performing students, they typically fare well with the school because they have a good relationship with the school and the counselors, everyone who is a part of that kid's academics. And so sometimes what they can just do is freeze that grade, especially if there's just a couple weeks left of school. They can freeze it from the time of injury, and then if they've learned enough content, they can just move on to the next grade. If it happens earlier in the school year, they can freeze their grade, drop the class, and take it again the following semester. Some kids have their 4 years of high school planned out from the time that they're a freshman, and that's not an option for those high performers. So summer school, also not a popular option, but some schools that offer a summer class can kind of help get them caught back up onto their academic plan, so that way they stay the course and stay in their same courses that they were planning on attending. Repeating a course, also never a great option for kids, but it is out there. Usually these classes are offered multiple times, especially with block scheduling. I know Millard does block scheduling, so they have a little bit more flexibility where courses are offered more often, so that's something to keep in mind. Dropping classes and switching to a study hall, that's something that sometimes we recommend, especially if we only want them to get through and get their core classes completed. So if they're not going to participate in a PE class or a band class because of their physical symptoms, maybe it's okay to drop that class and give them a study hall, so that way they can use that time either as a rest hour or catch up on some help. And most schools have a great counseling center and are able to provide that academic assistance. So something else that we had talked about earlier today, and I'm not going to go into detail about any of these, but all of these underlying conditions, for some students, if they've already had them, the concussion can bring out those symptoms and sometimes make the concussion a bit worse. Some students maybe didn't know that they had these, or it was the concussion kind of helped reveal these diagnoses, and so what we want to do is heal the concussion, get them back into their normal activities, and then go get help for all of these other concerns. So that's something just to kind of be aware of, especially with visual problems. Some kids might need glasses, and that's not because of the concussion, but they just had those struggles prior to the injury. So overall, today, the lesson, we all know each concussion is unique. So not every single student is going to need every single one of these academic accommodations. They can be informal or formal. And like I had spoke about, you do not need a doctor's note to start these accommodations. That's really important to note because the school knows what that student was like prior to injury. They know what kind of student, like what kind of performer they were in the classroom. And the doctor does not always see that patient often, like 3 or 4 times throughout the time of injury, whereas that school is seeing that child every single day. So that's also why it's important, because we don't want the doctor's office to dictate when they can and cannot have these accommodations, because that child might get better within that month before they see the doctor again for follow-up. And so if the school wants to let them try a few more things in the classroom or alter their accommodations, the school needs to be able to do that. There is a state law we talked about, and communication is key, which is what we have reiterated time and time again today. I talked really fast. So that's it. Any questions? Yes.
Becky, you had it on one of your accommodation slides, but can you touch on rimmed hats versus sunglasses for light-sensitive kids?
Yes, good question. So previous to just in the last six months to a year, we have been recommending kids are able to wear sunglasses in the classroom because that helps with the light sensitivity. And what new research has found, that that's actually making it worse, because when they take their sunglasses off, they're even more sensitive. So it's more important, a hat, a brimmed hat. Most schools have that as a policy. Hats are not allowed. But the hat actually helps because it more shields from the light instead of blocking those lights, which helps. Good question. Anything else? So a lot of that goes with their evaluation process and their interview, like we have talked about previous to. So when doctors ask about, tell me about school, what kind of struggles do you have? And some kids aren't entirely honest in the doctor's office, and so sometimes we hear a couple sides of the story, and so the student might report multiple symptoms to the doctor, and so that kind of helps in our office provide a better note for the school of accommodations that will help for that student. But we also get students who say, school's fine, everything's great, and then we might talk to the school as part of our process and find out that they're really struggling, they're not showing up, or they're not checking in with who they're supposed to be, and so that kind of hinders their academic accommodation plan too. So, and with Return to Learn not being super formal, like the Return to Play process is very stepwise, it has to go this, before this, before this. It just is so variant because each patient is different and what they present with is different. So they might receive a few accommodations in the classroom and then be fine. Other students, that might not be enough, and then we need to keep adding more and eventually put them on a special ed plan. So it's all still so gray. Anyone else? Okay, thanks.
Today, we've definitely seen a term where we're talking about sports-related concussion. We're talking about the pediatric population. I'm going to switch gears and really talk about the adults. And kind of like what Josiah was saying, where it's the wild, wild west, I really feel like that is the case in adults when we're talking about concussion and mild traumatic brain injury. Because really a lot of the literature and where we're taking information from the Buffalo Treadmill Protocol from Dr. Letty and the Berlin Consensus Statement, that's all on sports-related concussion. So the literature as it relates to adults is not as robust. And adults are a little bit more tricky. That's where, in my practice and what we do at Madonna, the majority of our patients are adults in the workforce that are having persistent symptoms, and how we manage those patients to get them back to work. Because being an occupational therapist, that's always a misnomer is, oh, you help people find work. But occupations, anything that fills your day, and for adults, that's how we see ourselves. That's, the main thing that we do is our employment, and is very meaningful. So when a concussion occurs and it can impact their ability to either work their normal hours, their normal job descriptions and responsibilities, or not be able to work at all, it can create a lot of stress. And that's always the number one goal that I hear, especially when a concussion has taken an individual out of their workplace. I would need to get back to work. So there's lots of different ways that we experience these concussions. I do talk to a lot of work comp companies because this is very different in how we manage these injuries versus, carpal tunnel and other orthopedic injuries that might occur in the workplace. So here are our objectives, which you can read through. We've talked about this throughout the day, so I won't beat the dead horse. And how they occur. And this is the same in the workforce. Is usually what I'm seeing in my practice is the individuals have fallen from, a ladder or whatever they're doing at work. So it's usually falls. If driving is involved in their work habits and they have to drive for work, sometimes it occurs from a motor vehicle collision during their work hours. Or they're that weekend warrior, or something happened at home and it's not necessarily a work-related concussion that happened at work, but it happened outside of work, but is again affecting their ability to go back to work. And here's just more. I'm a visual learner. Dr. Lancaster talked about what's happening at the cellular level that we can't pick up on CT or MRI. And this is why those symptoms are occurring, is because what's happening at the cellular level in the brain when these concussions occur. The pathophysiology, can begin at 1 minute, persist for 24 to 48 hours. That brain enters that energy crisis. So, as the neurometabolic cascade is occurring at the cellular level, just the cell swells, and there's edema in the neuron. And so I kind of try and put it in simplistic terms. When we have a knee that's swollen or an ankle or we jam a finger, it doesn't work well. It hurts and it doesn't work well like it's supposed to. And that's the same thing with the neurons in the brain when that acceleration, deceleration forces occur and they have that concussion. And so, 4 categories, again, we've talked about those today, so I won't go through them. But why is it important to address these in the adult population as it relates to work? This is a very expensive injury. And I think especially, talking about adults, because we're older and how we perceive concussion has changed so drastically in the last 10 to 15 years, if not even more recent. Me, I'm a 1999 high school graduate. But when I was playing high school sports, it was like, if you hit your head, get back in there. There was no legislation. There was no, they just didn't look at this injury as seriously. And so that really is the paradigm that a lot of the adults still come from is, I hit my head, it's not that big a deal. So unfortunately, we're not seeing these patients, at least at Madonna, until they're in a really bad shape. Because they think, I just, hit my head, I got my bell rung, it's okay, I'll be fine. Get back in there. And so 2 months, 3 months, sometimes 6, 9 months later, they're coming to us and they're like, I have all these symptoms, I haven't been able to work, I can't sleep at night. And so then the cost of this injury can become very expensive. So as far as loss of work and healthcare expenses, about $17 billion a year nationally, which equates to about $85,000 per injury. So it's very expensive. So the sooner we can get on top of this and evaluate those patients, hopefully the better outcomes and the sooner that they will get back to work. So I talked about this, most injuries on the job, motor vehicle accidents, falls, contact with objects and equipment. And again, this is very much the same if the injury happens outside of work hours. Rural construction and transportation workers are at the highest risk to have a concussion during the workday. So what do you do if you have a concussion at work? This, I always think, is probably important even if the concussion happens when you're not at work, but alert your supervisor and be evaluated by a healthcare professional. Again, I think this is something that we miss in the adult population because we just tend to brush it off because we don't historically don't understand it like we do today. And if you're not in the medical profession, you're not getting this information. You know, there's stuff on the news about sports-related concussion, CTE, but if you're not an active athlete, you just don't even think about it. And so being evaluated right away by a healthcare professional, because then they can at least get a baseline of symptoms. What are your acute symptoms shortly after this injury happens? Because then we can monitor the symptom progression or regression. And then best practice, it's recommended in the literature for a reassessment. So 2 to 3 weeks is kind of the common for 80 to 90% of the population to have resolvement of symptoms. You know, even if you're feeling fine, let's go back in and just check, because then we can, go through the checklist and make sure everything's healing the way it should be. The symptoms are resolving, if not completely gone, go back to your regular activity, so on and so forth. If not, and the symptoms are still there, 2, 3, going on 4 weeks post-injury, then we need to address it and get on top of it versus playing the wait and see game. We talked about earlier when to go to the emergency department, so we won't talk about that. And yes, good news is that for most, the recovery from a concussion or mild traumatic brain injury is not complicated. Most don't require any therapy or intervention. From the adult perspective, again, when it's affecting school and things we've talked about in sports-related and pediatric concussion, absolutely, let's, get them what they need so that they can be reintegrated into the classroom as soon as possible, so that they don't lose those school days. Majority are symptom-free within 3 to 4 weeks as an adult. And the key is to stay away from any high-risk activities during recovery. That's not something we're really focusing on today, but that risk of repetitive head injury and repetitive concussion, because most concussions that are second, so you've had one, the second one usually occurs within 10 days of the first, because people are not protecting themselves, or again, not staying away from those high-risk activities. And as the literature is continuing to come out, we know that there are changes and there are risks to having repetitive concussive and subconcussive blows to the head, and what that does to the brain neurologically and long-term. So returning to work, whether this injury happened at work or outside of work, how do we get these individuals back to work? Concussion and mild TBI is not a significant risk factor for long-term disability. The literature shows that on average, for healthy, and I always find it interesting when I'm reading about mild TBI in the adult population, they always preface it with healthy adult individuals will return back to work on average within 16 days post-injury. 75% who are receiving workers' compensation resources and benefits went off those within 2 months. So again, not a huge risk factor for being off work for a long period of time. However, that is what we see at Madonna a lot of times, are people who have been off of work for weeks or months because that concussion has not been managed appropriately from the get-go. So what to do while recovering as an adult? As we know, recommendations have drastically changed. Now it's a big no-no, no strict rest, and what they're finding in the studies. Return to light activity within 24 to 48 hours, whether that's walking, light aerobic exercise, housework, and letting the symptoms be your guide. And this is where that education piece comes in. As part of my job at Madonna and going out in the community, if I can get in front of providers at any level, practitioners, again, I'm in the work comp companies talking about how to manage this, is, the quicker we can get them back to activity, either at a sub-symptom threshold or, symptoms that are manageable, the better that patient's going to do. And how quickly can we get that individual working with the supervisors, working with the employer, back into the workforce, even if it's in a modified capacity. So it sounds very similar to the classroom, and that's what's considered best practice, even for adults, is people do better if they can get back into the workforce at some capacity. And even for that mental and psychological perspective, If you're somebody who works full time and then all of a sudden it's like, oh my gosh, I can't work and I'm having all these issues and how am I going to get back to work? And it's just that vicious cycle and that snowball effect where then it gets, with those prolonged symptoms, which are going to be talked about here in the next lecture, we start to get into what came first, the chicken or the egg. Is this now the symptoms are exacerbated because there's so much psychological stress with being off of work, financial stresses, if there's litigation involved with the injury, that, it just snowballs. And then it's hard to differentiate, are these psychological symptoms exacerbating concussion symptoms, or are these still very true concussive symptoms from the concussion? So we do call these individuals the miserable minority that don't have that normal recovery time frame where within 2, 3, 4 weeks tops they're back and symptom free. And definitely, when these people come into our practice at Madonna, they are miserable. They now have a laundry list of complaints and symptoms, and that it's getting worse, and they can't go outside, they're at home all the time, they aren't able to drive, and they really are miserable physically and psychologically. So when these persistent symptoms occur, it obviously delays a return to work. So those individuals who still have persistent symptoms, outside of that normal time frame of recovery, they still do return to work, but it is protracted. Instead of 16 days, now we're looking at 3 to 6 months. So, all of us who are employed think of being off of work 3 to 6 months. Maybe some people are like, yes, that would be awesome. I myself would go crazy. I was on maternity leave for 12 weeks with both my children. The first one, 2 weeks, and I was like, yeah, I'm not having any of this. How soon can I get back to work? So 96% of healthy adults post-concussion or mild TBI returned to work at 1 year and had returned to work at 1 year follow-up. So again, they're returning to work early, and 96% 1 year post-injury are all back to work in their full capacity. So some things that we look at that kind of start to give us a clue and some prognostic indicators of how this injury is going to play out, especially when there's prolonged symptoms, is how much psychological distress is going on with this individual, as it's related to the injury, as well as not necessarily just the injury, but what are all their other external psychosocial factors? Family stress, marital stress, financial stress. How is that all playing into their recovery and how they're able to cope and be resilient as they heal? Decreased global functioning. So if they have a lot of symptoms where their symptoms are impacting every aspect of their daily function, they're going to have a protracted recovery and delayed return to work. The longer you're off of work, the longer you're going to be off of work. So 2+ months leave from work, the longer you're off, the less chance you're going to have to be going back to work in your full capacity at 12 months. And then premorbid and comorbid diagnoses, which we'll talk about as well. So if there were issues prior to the injury or the individual had other health issues prior to the concussion, that's going to impact their recovery and their ability to return to work, hopefully by that 16 days post-injury that we talked about. It could be months before they're able to go back to work in their full capacity if they have these other issues going on. Other predictors, the literature shows if it lower level of education. So those that, have a high school degree or less than that, maybe not a college degree, they seem to, after these injuries, not go back to work in their full capacity or not go back to work at all. Nausea and vomiting at the time of injury, obviously that's indicative of a more serious concussion / mild traumatic brain injury. So yeah, the recovery is going to be longer because it was a more severe injury. If there's extracranial injuries, lacerations to the head, other external hematomas, fractures from a fall, again, indicative of a more serious injury, which is going to make recovery longer. Severe pain shortly after the injury, and also what was their job like before? Did they have limited job independence and autonomy? You know, that's what we always look for, most of us, in occupation and job opportunity. So if you have that, is there a ton of motivation to keep pushing forward to get back to work? And so what they find is those jobs that have that limited autonomy and independence, those individuals don't seem to get back to work as quickly. Delayed recovery group may not respond well to standard therapy. Dr. Lancaster talked about, you know, limiting medications. What I see a lot is this piecemeal approach, unfortunately, especially with work comp cases. You know, you have that support when through adjusters and work comp case managers when your injury happens at work, but unfortunately, it's not, you know, carpal tunnel or a rotator cuff or an orthopedic injury. They really struggle on what do we do with this injury and what do we do with this person now that, you know, we're 2 months out and they're not getting better. And by the time they get to me, they have seen probably 5 different doctors, have been on 10 different medications, have been to a psychiatrist, a neurologist, physical therapy, so they've seen a lot of specialists, but none of those specialists are talking to one another because they're not working on a team. And so what we've found is that piecemeal approach just does not work for this, for the adult population or that individual that's having prolonged symptoms. So we need to come at it much differently. And I'm not going to go through this because this will go into the next with the symptoms of persistent post-concussive symptoms. So common comorbidities. So again, that individual who has, you know, as an adult, we have life experiences, and you probably aren't as healthy as those young pups that are playing on the football field. So, you know, have there been issues with post-traumatic headaches prior? Whether that's, you know, they've had previous concussions, they have headaches from, you know, migraines, they were just prone to more headaches naturally. Do they have premorbid balance and vestibular disorders or comorbid issues, which Josiah talked about? Whiplash, you know, are the symptoms coming from a cervicogenic perspective? Do they have orthopedic pain? Did they have chronic pain issues prior? Do they have rheumatoid arthritis? Do they have osteoarthritis? You know, what was going on before? Were they good sleepers before? You know, as adults, we tend to become poor sleepers for a multitude of reasons. And so how is sleep hygiene and sleep habits before, and sleep patterns? And then depression, anxiety. Depression's probably one of the most common treated complaints across the nation. I don't know what the statistics are, but I know when I read an H&P, you know, 90% of my patients have it on their H&P prior to their injury. So again, how is that impacting their recovery and their ability to cope with this concussion? So treatment, that initial physical exam, which Dr. Lancaster went through, so I won't go through that. We talked about the follow-up exam and how important that is. Again, if symptoms are resolving, you know, great, check you off, send you on your way, but if you're still symptomatic, we're going to catch it early so that brain doesn't get into a bad pattern. Also differential diagnosis. Again, especially in the adult population, what else is going on that is either mimicking concussion symptoms or playing a role in the severity of symptoms? You know, what kind of concussion? This goes into that treadmill protocol and how we assess, is it a physiological concussion? Are the symptoms coming more from a cervicogenic perspective, or are their symptoms more vestibular ocular based? And then we treat those symptoms. And so here's where because there can be a multitude of symptoms coming from various sources, a multidisciplinary treatment team is what's recommended. And even with sports-related concussion, in that consensus paper out of Berlin in 2016, this is what they recommend for all concussion management, especially if there are those persistent symptoms, is that multidisciplinary treatment approach. And this is who it includes. Your physician, whether for Madonna, that's a physiatrist, a medical specialist in rehabilitative medicine. You know, it can be your primary care physician, it can be the pediatrician in the pediatric population, but that physician is kind of driving the bus. But then we have all those rehabilitative specialties: physical therapy, occupational therapy, speech therapy, neuropsychology. Again, they play a very important role to be able to, you know, go through the assessments in the battery and standardized testing to see where do they fall on the bell curve. Are they normal, abnormal? And then differentiate, are these concussion symptoms, and are there deficits that they're demonstrating on these assessments is concussion related, or is this more psychological? Rehabilitation counselor for our practice is very important, again, to help as we go through the recovery process, and especially with the adults that are off of work and dealing with the stressors that come with that, being able to cope and have that resilience and being able to talk through some of the things that they're experiencing. We are very fortunate at Madonna that we have 2 staff neuro-optometrists. You've heard a lot about the neurological vision changes that can occur with a head injury. Whether that's mild to severe, 90% of individuals with a head injury will have some type of neurological vision change. So that's one of the first things that we take a look at, because 80% of our sensory information comes from our eyes. So if we're not receiving sensory information from our environment accurately, we're not going to be able to respond appropriately to our environment, and it's very noxious to the brain, whether that's double vision, blurred vision, so that can exacerbate symptoms as well. So as an occupational therapist, we work hand in hand with our neuro-optometrists. They do the full assessments, they look at acuity, they will refract, they do their binocular assessments, and then give us a plan of care. Like, this is what we need to do in your therapies to address these vision deficits. And then again, I'm talking with my physical therapist that I'm treating with what's going on from the vestibular perspective, because vestibular and ocular are so closely tied together and impact one another. And then we have a social worker / case manager to be helping kind of, you know, navigate the waters of healthcare, because if you're not experienced with it, it gets really complicated. Whether that's, you know, your private insurance, are you getting these services through Medicaid, is this going through work comp, as well as once you're done with therapies and working with this multidisciplinary team, what are your resources once you've been discharged from the medical institution? Because, you know, for some of these individuals, symptoms might not 100% resolve. And so what resources and supports can we put in place to help this individual long term? So treatment focuses on the symptoms. So we've talked about this a multitude of ways today. We integrate, again, working more primarily with the adult population. We have a work reentry program. And whether you're seeing adults in the private practice or at a facility like Madonna, be thinking, what are their work responsibilities? What are their job-related tasks, physically, cognitively, mentally? And how can you integrate that into your treatment? And how can you give them exercise programs at home that mimic and simulate job responsibilities? Because again, we're trying to get that individual back into the workforce if they, because the severity of their symptoms, have eliminated their ability to be at work at that time. And again, from a psychological perspective, I find when I put my patients in that work reentry process, where they have certain therapies strictly focused on their work responsibilities and starting to work towards full integration back into their job, their psychological, mental state just seems to improve, because they feel like, okay, I'm getting better, I'm working toward getting back to work, that's what I want, I feel like I'm making progress. Just a little bit on that neuropsychological assessment. I get this question all the time. Of why it's important, when do we do it, and this really does come in handy and is imperative in those chronic phases of recovery where we have those prolonged symptoms. Again, to be able to assess the multiple facets of cognition. Cognition is just, we take it for granted when our brain is working normally, all the things that our brain's able to do from a cognitive perspective and executive functioning. when that brain is injured, things that seem so simple can become very difficult. And so being able to assess those facets of cognition, identify the deficits as well as the strengths, and provide clinical assessment of the presence. Is this a concussion, mild TBI, or is this more psychologically based? Provide recommendations for further treatment, whether that's therapy, pharmacological management, counseling, and environmental modifications. How we run our multidisciplinary comprehensive clinic is, even though that treatment team physician was listed first, they're the last ones to see our patients when they go through this clinic. All the other specialties and disciplines do their assessments, write up their evaluations and recommendations, and send them to the physician before our physician sees our patient. Because then he can read through everything and then make further recommendations based on our recommendations, which is really helpful. So our neuropsychologists sometimes will make a statement in their write-up of, pharmacological management and potentially what medications, and then our physician can, take those recommendations and do what he feels is best practice for that patient. The nice thing, too, about neuropsychological assessments is they're standardized. We love numbers and that objective assessment. Well, we can get a score when we first see the patient, but then we can continually reassess and see how their scores are improving, or are they not? Or now something else has happened in their life and lifestyle, and now they're scoring worse. So we can see that progression and modify our interventions accordingly. We talked a little bit about controlled exercise and why that's important. I'm a runner, and so it's seems to be a no-brainer to me because I get the runner's high, and it's like, oh my gosh, it feels so good. So that exercise, not only for concussion, there's a lot of research coming out with even moderate to severe TBI, and stroke for sure. If we can get our patients exercising and getting their heart rate up, however that may look, they do better and they have better outcomes, even with the more severe injuries. So exercising 5 to 6 days a week at 80% subsymptom threshold. So again, what Josiah was talking about with monitoring heart rate, giving them a protocol of, here's what I want you to do for exercise, and here's where I want you to be training in that heart rate zone. Return to work activities. So 2 to 3 days rest period, we talked about that, and gradual engagement in physical and work activity. So again, outside of work is that light exercise, reading for shorter periods of time, computer work. So many of our jobs are based around computers and technology now, and that can be really stressful for the brain after a concussion, to be staring at a screen, using both eyes, reading. There's a lot of cognitive load with that technology use, and can really exacerbate symptoms. So, so many of adults were all or nothing, I'm going to go full force, or I can't do it at all. But helping them manage expectations of, yes, you can still do this, but it may not be for 3 hours at a time. It may be more 15 minutes, take a break, come back. Go another 15 minutes, take a break, and come back. You can still get your work done. It's just going to be modified and look a little different than how you were doing it before, until we get your symptoms under control and you feel like everything's resolved. Where it gets a little tricky is those manual and physical labor jobs. Because again, they're high-risk jobs where you're at a higher risk for sustaining a secondary concussion. It's more physical, so more physical activity could exacerbate symptoms. So really, we try and teach our patients, and it does get a little bit easier when it is a work comp case, to work with that employer and supervisor of, how can I get physically back into the building and back into the location, maybe not doing my physical job, but again, transitioning. Is it paperwork? Is it filing? Is it, scheduling and doing more clerical work until, again, I'm getting better and recovering, and then start to reintegrate back into those more physical, demanding job responsibilities. So again, Those factors do facilitate more successful work reentry if we can use those compensatory strategies and those modified work schedules and work responsibilities. I feel like this is a duplicate, sorry. So that chronic symptomology, again, we'll talk about it in this next lecture. So it's relatively uncommon for cognitive, psychological, and psychosocial problems due to the biological effects of concussion to persist longer than 3 to 6 months in the adult population, which commonly at Madonna we see patients who are further out than 6 months. So we really have to then take a look at what is going on and how should we treat. Education's power. I find my patients really struggle when they've seen a provider with their symptoms, whether it's acute or chronic, and they're like, well, I have a brain injury, this is what life is going to be like now, and they just like freak out. So positive reframing, there is an expectation that you will get better and your symptoms will get better. And so we're really trying to prevent those iatrogenic effects that the medical profession can have on a patient and those negative effects, and promoting healthy lifestyle behaviors, you know, whether that's sleep hygiene, stress management, and obviously that physical exercise. We do a lot of cognitive behavioral therapy, focusing on that associated depression and anxiety and many times chronic fatigue symptoms, biofeedback, relaxation training. Again, we're treating the physical symptoms through OT, PT, and the cognitive symptoms with neuropsychology and speech. And we really try and normalize that discomfort. You know, how many of us without a concussion have headaches sometimes? Probably most people in this room. How many of us will have a sleepless night here or there? Probably most of us. I facilitate a mild TBI/concussion adult support group that we have once a month. And I always kind of have to, you know, and some of these patients are acute dealing with their injury, and some patients are months and years post-injury, and they still come to support group because, again, very high functioning, have high expectations of themselves. There's this one gal that comes consistently, and she's back to work full-time, working mom of 3, and she's like, you know, because of this concussion, I now have to make the choice at the end of the day. Do I go to bed and get rest so I'm well rested, or do I go out and be social with my friends? And I'm like, I have to make that decision too because I'm a full-time working mom, and I'm exhausted at the end of the day too. And so just normalizing, like, that's so normal. That may not necessarily be because of the concussion. That's just life. And sometimes normalizing that discomfort really helps. You know, that they feel like, oh, everybody's dealing with something like this to an extent. And that also helps manage those anxiety symptoms. Long-term outcomes for these patients, especially in the adult population, if they haven't had that quote-unquote normal resolvement, you know, these are some of the long-term things that they will complain about, whether that's fatigue for over half as well as forgetfulness. But then as we read literature about just aging in the brain, well, is that aging in the adult population, the forgetfulness, or is it, you know, concussion related? It's hard to know. Poor concentration, drowsiness, and dizziness. So this study by Lasoy in 2016, again, prefaced it with healthy adults, but 93% achieved a favorable outcome and were symptom-free 1 year post-injury. Another one found return to work at 97% at 1 year. I always think in brain injury literature, the statistics are all over the board because it's such a heterogeneous population. You can't control for everybody's external variables, extraneous variables. So depending on what their study, even if it's return to work and concussion, you can see totally different numbers. So the bottom line is the wait and see approach is not ideal. You know, which again, I think is as adults, and if you're not up to speed on what the concussion literature and best practices today, you still are treating yourself by the recommendations that were decades ago. So the wait and see approach is not ideal, but a lot of times that's what the adults are doing. The odds of return to full employment following a medically related incident drop to 50-50 after 6 months of absence. So again, the quicker we can get individuals back into the workforce after an injury, especially concussion, the greater chance that they're going to get back to full capacity and not be on long-term disability. Less encouraging, the odds of a worker ever returning to work drop 50% just by the 12th week. So again, the quicker we can get them back, the higher the chances that they'll get back to full capacity. So we're all part of that concussion treatment team, you know, in supporting an early return to work and thinking outside the box on how we can make that happen. Implementing team recommendations and environmental modifications, whether that's at home or in the workplace, and supporting that employee and that worker in compensatory strategy use.